Good afternoon, everyone. Now we are going to study about amniotic fluid and its abnormalities. What is amniotic fluid? Amniotic fluid, also known as liquor amni, is a fluid that is present in the amniotic sac and surrounds the embryo. So it is a straw color fluid that surrounds the fetus during pregnancy, and it is replaced once every 3 hours. The osmolarity of amniotic fluid is 260 milliosmol per liter, and coming to composition, in the first of the half of the pregnancy it is identical to the transduate of plasma. That is, osmolality is similar to plasma except that it has lower concentration of proteins. But in later half of the pregnancy, it is derived from two components, water and the solid constituents. Water content is around 98%, while the solid constituents constitute 1 to 2%. Solid constituents includes proteins, that is albumin and globulin, certain lipids, glucose, inorganic salts, and suspended particles, which are the lanugo, vernix caseosa, exfoliated fetal cells. What is lanugo? These are the hair follicles or the hair of the fetus. Vernix caseosa is the whitish layer that is present over body of the fetus, and exfoliated fetal cells are also present in the amniotic fluid. So what is the function of amniotic fluid? So it function what are the functions during pregnancy and what are the functions during labor? During pregnancy, amniotic fluid serves as a cushion and protects the fetus from trauma. It maintains fetal temperature, allows free fetal movement and growth of the fetus, prevents adhesion formation between the fetal parts and the amniotic sac, which can be seen in oligohydramnios, where there is decreased liquor production and can lead to amniotic band sequence and certain abnormalities. Ingestion of amniotic fluid into the fetal gastrointestinal tract and inhalation into the fetal respiratory tract helps in the growth and differentiation of these tissues, as amniotic fluid has growth factors also. It has some nutritive value because of a small amount of proteins and salt content. So, moreover, the functions include it protect as cushion and traumatic प्रोटेक्शन प्रोवाइड करता है, मेंटेन करता है फीटल टेम्परेचर, अलाउज फ्री मूवमेंट एंड ग्रोथ ऑफ द फीटस, एडिशन को प्रिवेंट करेगा, एंड ग्रोथ ऑफ रेस्पिरेटरी ट्रैक्ट एंड जीआई सिस्टम उसमें रोल प्ले करता है. नाउ व्हाट आर द फंक्शंस ड्यूरिंग लेबर? एमनियोटिक फ्लूइड फॉर्म्स अ हाइड्रोस्टेटिक वेज टू हेल्प इन सर्वाइकल डायलिटेशन. During uterine contraction, amniotic fluid in the intact membranes prevent interference with the placental circulation. It provides pool for the fetus to excrete urine, protects fetus from ascending infections by its bactericidal action. So, overall functions include physical space for fetal movement necessary for neuromusculoskeletal development and maturation, protects the fetus from trauma, guards against umbilical cord compression, which can occur in oligohydramnios and can cause fetal distress. Amniotic fluid also has bacteriostatic properties. Fetal swallowing allows GI and respiratory tract development and fetal pulmonary development. It does not provide nutritive function for the fetus, and it is important for exam point of view. So, what is the color of the amniotic fluid? So, in early pregnancy, it is colorless, but as the pregnancy advances, its color changes to straw colored due to the presence of exfoliated lanugo and fetal cells. It may look turbid due to the presence of vernix caseosa also. So, these are the appearances of the amniotic fluid based on the conditions given. Straw colored amniotic fluid is seen in term pregnancy, colorless in preterm, dark blood stained when there is antepartum hemorrhage due to placental abruption. Tobacco juice appearance they seen in intrauterine death or IUDs. Saffron in post-dated or post-maturity. Golden colored seen in RH isoimmunization due to hemolysis, and green colored is seen in meconium passage. There is one prune juice or dark brown which is seen in prolonged retained dead fetus. Now, what is the physiology of amniotic fluid? In early pregnancy, it is similar to extracellular fluid, as we have already discussed that its Osmolarity is similar to the plasma except protein concentration is more in plasma as compared to amniotic fluid. The maintenance of amniotic fluid is a dynamic process throughout the pregnancy, and regulation in the first half of the pregnancy occurs by. So, these are the procedures through which the origin and circulation of amniotic fluid occurs. So, in early pregnancy or first half of the pregnancy, transmembranous flow occurs through transport of water and other molecules across amnion, intramembranous flow across fetal vessels on placental surface, transcutaneous flow across fetal skin. But with advanced gestation, the pathway helps in amniotic fluid regulation is fetal urination, which contributes majorly. Fetal swallowing and fetal lung fluid secretions, intramembranous flow across fetal vessels on placental surface, transmembranous flow across amniotic membranes. So this diagrammatical representation is showing circulation of amniotic fluid. So this is the placenta, and here net water movement between mother and the fetus across chorionic frondosome is happening. So this is the fetus and this is the amniotic fluid. Now first one is fetal swallowing. So amniotic fluid exchange can occur through fetal swallowing and reabsorption by the intestine. Also it can occur through respiratory tract via reabsorption by the lungs. Fetal skin cells can also participate before 20 weeks of gestation. Exchange across fetal skin possible only for small lipid soluble gases. Fetal urine is the major contributor in the later half of the pregnancy, and transfer across chorionic plate also happens. So this is amnion, then chorion, leve, and this is the chorionic frondosome, this is the placenta. So here the exchange is occurring. Now, so there are certain process through which there is production of amniotic fluid, and there are certain procedures which facilitates reabsorption of amniotic fluid. So fetal urination and fetal lung fluid secretion contributes to production of amniotic fluid, which is around 1350 ml per day, majorly contributed by fetal urination, that is 1 liter per day. Now fetal swallowing around 750 ml, reabsorbed intramembranous flow across fetal vessels on the placental surface around 400, and transmembranous flow across amniotic membranes minimal. So there is production of around 1350 ml of amniotic fluid daily, and 1150 is reabsorbed. So the net volume is 200 ml per day. Normal amniotic volume increases approximately from 30 ml at 10 weeks to 200 ml by 16 weeks and reaches 800 ml by mid-trimester. A full-term fetus roughly contains 280 ml of water and the placenta another 400 ml, such that the term uterus holds nearly 4 liters of water. As the pregnancy continues postpartum, there is reduction in the amniotic fluid because there is maturation of the fetal skin cells, and the amount of amniotic fluid at 43 weeks is just 200 ml. So in this diagram you can see with advanced gestational age amniotic fluid production is decreasing and it peaks at around 28 to 32 weeks. So this is showing the maximum amniotic fluid production at midterm gestational age. It is lesser at less than 10 weeks and it is lesser after 40 weeks of gestation. Now, measurement of amniotic fluid can be done by USG, and it is the most sensitive investigation which can detect the amount of amniotic fluid and predict the outcome of the baby. So measurement of amniotic fluid is done by ultrasonography, where we measure single largest vertical pocket, and also we can calculate the deepest vertical pockets in all the quadrants and then take sum of them. So what is single deepest pocket? USG transducer is held perpendicular to the floor and parallel to the long axis of the mother. In the sagittal plane, the largest pocket is identified. Normal range of single deepest vertical pocket is 2 to 8 cm. Fetal parts or loops of the cord are not included in the measurement. If the measurement is less than 2 cm for single deepest pocket, it is oligohydramnios, and if it is more than 8 cm, it is polyhydramnios. Now, coming to amniotic fluid index or AFI, it is the quantitative method of measurement of amniotic fluid. Here, we calculate the single deepest vertical pocket in all four quadrants and then we add them and divide them accordingly. Normal value of amniotic fluid index is 5 to 25, less than 5 is oligo and more than 25 is polyhydramnios. So this image is depicting the correct position of the transducer to be held while calculating the amniotic fluid index. It is to be placed perpendicular to the floor and measurements are taken in sagittal plane with no cord or amniotic with no cord or fetal part in the plane. So we divide the maternal abdomen into 4 parts and then we calculate the single vertical pocket in all those quadrants and then measure them. Now, coming to abnormalities of amniotic fluid, first one is oligohydramnios. What is oligohydramnios? Oligohydramnios is the abnormally decreased amount of amniotic fluid and it complicates around 1 to 2% of the pregnancies. USG diagnosis is based on either AFI or SDP as we have already discussed. Another condition is anhydramnios. Anhydramnios means absent water, means there is no measurable pocket of amniotic fluid seen. In evaluation of multifetal pregnancy for twin-to-twin transfusion syndrome, a single deepest pocket below 2 cm is used to define oligohydramnios. So what are the causes of oligohydramnios? The causes could be fetal, maternal, placental or iatrogenic causes. Fetal causes, any cause which is disrupting the intake of amniotic fluid causes oligohydramnios, like chromosomal abnormalities, congenital abnormalities, growth restricted babies where kidneys are not going to function properly and urine production is lesser, IUD or fetal demise, postpartum pregnancy where inherently liquor is reduced and ruptured membrane. Maternal includes uteroplacental insufficiency, hypertension, preeclampsia, and diabetes. Diabetes causes both poly and oligohydramnios. If there is vascular abnormality, then oligohydramnios occur, and if there is no vascular abnormality or uteroplacental insufficiency, then polyhydramnios can occur. Now, placental causes, abruption, twin-to-twin transfusion syndromes, and certain idiopathic causes also. Iatrogenic causes includes drugs like ACE inhibitors and prostaglandin synthesis inhibitors. So these are the causes of oligohydramnios. Now, what are the congenital anomalies associated with oligohydramnios? Congenital anomalies include amniotic band syndrome. Can you see the legs of the baby? These babies' legs have been compressed due to reduced liquor and abnormal shape you can see in this image. So, amniotic band syndrome. Cardiac abnormalities include tetralogy of Fallot and septal defects. CNS abnormality includes holoprosencephaly, meningocele, encephalocele, microcephaly. Chromosomal abnormalities like Patau syndrome, Turner syndrome, triploides, cloacal dysgenesis, cystic hygroma, diaphragmatic hernia, genitourinary disorders like renal agenesis, renal dysplasias, urethral obstruction, bladder extrophy, Mackel-Gruber syndrome, uretropelvic junction obstruction, prune belly syndrome, etc. Hypothyroidism also causes oligohydramnios in the baby. Skeletal abnormalities like sirenomelia, sacral agenesis, absent radius, facial clefting, trap sequence also known as twin reverse arterial perfusion sequence, twin-to-twin transfusion syndrome, and vectoral anomalies. Vectoral anomalies includes vertebral, anal, cardiac, tracheoesophageal, renal and limb abnormalities. So, how will you diagnose this oligohydramnios? So, first of all, when you measure the perabdomen of the mother and you do perabdominal examination, then the uterine size is smaller than the dates of the baby. Fetal movements might be perceived less by the mother. There is absent or reduced fetal movement. Malpresentation is common. And oligo with fetal symmetrical growth restriction is associated with increased chromosomal abnormality risk. History of leaking can also be there. Now, what is the management? We will tell the patient to get adequate rest. Hydration is important. We can serially monitor the AFI through ultrasound monitoring. We will monitor for the growth, biophysical profile, and amniotic fluid index in a serial way. Induction of labor or LSAs can also be done. Amnio infusion can also be tried, and archiprac sachets, which has L-arginine, uh, that is thought to be improving uteroplacental blood flow by increasing nitric oxide and causing vasodilation, can also be tried, but it is under trial. Now, coming to another abnormality of amniotic fluid, which is known as polyhydramnios. In this condition, there is an abnormally increased amniotic fluid volume. So, the Liker amount increase in this condition. It can be diagnosed by USG. If more than 8 cm SDP or AFI is more than 25 centimeters, then it is poly. It is further divided into three parts, that is mild polyhydramnios, moderate polyhydramnios, and severe polyhydramnios. If the AFI is between 25 to 29.9, or SDP is 8 to 9.9, or in simple terms 25 to 30, 8 to 10. Moderate is 30 to 35, and SDP is 10 to 12. Severe is 35 or more than 35 centimeters, and SDP more than 12 centimeters. So 5 difference for AFI and 2 difference for SDP. So here we are classifying it as mild, moderate, and severe. Now, what are the causes? Causes can be maternal diabetes, which can cause both oligo and polyhydramnios, GI abnormalities like esophageal atrasias, duodenal atrasias, non-immune hydrops fetalis, CNS abnormalities like open spina bifida, chromosomal anomalies, congenital infections, chromosomal abnormalities, high output cardiac failure, fetal anemia, placental tumors like cholangiomas, multifetal pregnancies, and idiopathic. So how will you diagnose this? When Liker is more in amount, the uterine size increases and patient can present with certain symptoms like dyspnea, palpitation, edema due to vascular stasis, oligouria due to ureteral obstruction by the enlarged uterus. So in mother, oligouria can occur. Abdomen is markedly tensed, shiny, enlarged globularly, and complications such as preeclampsia, premature rupture of membrane, preterm labor, cord prolapse, placental abruption, and postpartum hemorrhage can occur. So what is the management of polyhydramnios? First of all, we will try to treat the underlying cause which is causing polyhydramnios. In case of maternal respiratory distress, large volume amniocentesis termed as amnioreduction can be tried, where we insert a 18 to 22 or 20 gauge larger needle with evacuated container bottle, and we try to evacuate around 1 to 2 liter of fluid in 30 minutes slowly. But in this procedure, certain complication can occur like abruption, etc. So preterm labor abruption can also occur. If patient is diabetic, we will try to control her blood sugar levels and bring down the glycemic index at a normal range. Delivery can also be tried, but for delivery, controlled ARM can be done prior to induction, because if controlled ARM is not done, then patient can land up into preterm labor or premature rupture of membrane, or even cord prolapse abruption can occur. Indomethacin, which is a drug that reduces amniotic fluid amount or synthesis, can be given in a dose of 2.2 to 3 milligrams per kg per day. Decreased amniotic fluid, as it results decreased urine output. So it will decrease the urine output of the baby and in turn decreases the amniotic fluid. Thank you.